Hello everyone. I am Dr. Akansha, Assistant Professor in Department of Neonatology at SGPGI Lucknow. And in this lecture, we are going to discuss about the physiological basis for principles of neonatal resuscitation. And the specific learning objectives of this presentation would be to discuss regarding the transitional physiology from fetal to postnatal life and the principles of neonatal resuscitation. So, the transition from fetal to neonatal life involves a sequence of complex, rapid, and well orchestrated physiological events. Most of the babies would be able to make this transition without requiring any assistance, but 5 to 10% of the babies require varying degrees of resuscitative interventions at the time of the birth. A key initial step in neonatal resuscitation is temperature regulation by providing warmth, and the most crucial event in the entire neonatal resuscitation is lung inflation or ventilation of lungs with optimal concentrations of oxygen. Birth asphyxia is one of the top 3 causes of neonatal mortality globally and in India, and it makes subsequent effects on the transitional physiology. So it is imperative and must to understand the cardiorespiratory transition at the time of the birth and what are its impact on the subsequent steps of resuscitation. Because if we know well the transitional physiology, we can handle the challenges occurring at the time of resuscitation. So, before moving on to transitional physiology, let us know something important about the fetal circulation. The fetal circulation is entirely different from that of the postnatal circulation in some ways. The placenta acts as the main organ of gas exchange for the fetus because the fetal lungs are filled with fluid. There is negligible or almost no gas exchange that takes place in the fetal lungs. So, the placenta supplies the oxygenated blood to the fetus through the umbilical vein, which splits at the level of the liver. Some part of it perfuses the hepatic circulation, and the majority of this oxygenated blood is shunted via the shunt known as ductus venosus. It will take this blood into the right atrium. But there is another shunt present here, that is the foramen ovale, and this helps to distribute most of the umbilical venous oxygenated blood and shifts this into the left atrium. So the majority of this umbilical venous oxygenated blood enters the left side of the heart, and a very small portion of it will enter into the right ventricle. Also, since we said that the fetal lungs are filled with fluid, so there is a very low flow pulmonary circulation in the fetus. So the pulmonary vascular resistance is very high. Another shunt, that is ductus arteriosus, exists between the pulmonary artery and the aorta. So, since the pulmonary vascular resistance is very high and the blood tends to shift from high pressure to low pressure, so the flow in the ductus arteriosus is again from right to left. So we now know that umbilical venous return is the primary source of left ventricular preload in the fetus because there is no pulmonary circulation. So there is no pulmonary venous return coming to the left side of the heart. There are 3 major shunts. Right to left shunt across the foramen ovale and ductus arteriosus, and we have a very high resistance and a low flow pulmonary circulation in the fetal life. Now, there are some typical features of the transitional circulation, and some of the important points of these are that as soon as the baby is born and the umbilical cord is clamped, so as soon as you clamp the cord, there is a decreased umbilicus blood flow, because the source of the umbilical venous supply, which was coming from placenta, is lost. So there would be a decreased umbilical venous blood flow going into the RA and hence into the right atrium. Another very important change occurring at the time of birth is that with the start of the neonatal breathing movements, like as soon as the baby cries or breathes, it leads to an ingress of air into the alveoli of the lungs. So, with next few breaths, this fetal lung liquid is gradually replaced with air, and this is a very important transitional uh, point occurring at the time of the birth. So, with the replacement of the lung liquid with the air, there occurs pulmonary vasodilation. So, this room air coming with 21% oxygen acts as a very strong pulmonary vasodilator, leading to a decrease in the pulmonary vascular resistance, which was very high in the fetal life, hence improving the pulmonary blood flow and increasing the pulmonary venous return. So the pulmonary veins will now be carrying the blood from lungs into the left atrium. And since the cord has been clamped, so the low resistance placental circuit is lost. And with the constriction of the umbilical arteries, there is an increase in the systemic vascular resistance. So we saw that at the time of the birth, there are these important changes that take place. With initiation of breathing and the clamping of umbilical cord, newborn will now use lungs instead of placenta for the gas exchange. As the lung fluid in the alveoli is absorbed, air will replace this and the oxygen will move from alveoli into the pulmonary blood vessels and CO2 would be exhaled out. And this air will cause the blood vessels in the lungs to dilate and the pulmonary blood flow will increase. And as the pulmonary vascular resistance falls, the ductus arteriosus gradually constricts. And we can see in this graph that minutes after birth, there is a very high, almost a 30-fold increase in the pulmonary blood flow. There would be a rise in the systemic arterial pressure as the low resistance placental circuit is lost, and there would be a gradual fall in the pulmonary arterial pressures. So, though most of the newborns would be able to make this transition by themselves without any assistance, but there may be up to 5 to 6% of the babies who may not initiate breathing or may not be able to establish successful breathing. So, they may require positive pressure ventilation to establish respiration. It is important to remember that in neonatal resuscitation, it is mainly because of the is required mainly because of the respiratory failure, because the lungs fail to take over as the organs of gas exchange. So it is crucial to start positive pressure ventilation. Bag and mask or a T-piece resuscitator may be used with an appropriate sized mask for providing the positive pressure ventilation, and it would be indicated by a rise in heart rate occurring within 15 seconds of initiating positive pressure ventilation, leading to a rise in the arterial blood pressure. And if at all we are not able to get effective chest movements or a rise in the heart rate, then the troubleshooting is done using ventilation corrective steps sequentially. So there's an acronym for this, MR SOPA. So these are ventilation corrective steps that should be taken in an order sequentially. So M stands for mask adjustment, Re is for repositioning of the head and neck. If that does not help, then move on to S, that is suction mouth and nose. O is for opening the airway. Perform these steps together and then increase the pressure and finally using an alternative airway. Now, regarding the non-vigorous meconium-stained amniotic fluid babies, so for many decades we have practiced tracheal suctioning and avoiding the initiation of positive pressure ventilation in babies with meconium-stained amniotic fluid. But there is now enough evidence to prove that withholding the initial steps or provision of positive pressure ventilation to perform intratracheal suctioning is no longer recommended because it delays the initiation of positive pressure ventilation, and precious moments may be lost during this process. So only it is recommended to do intratracheal suctioning if the airway obstruction is suspected because of thick meconium, or you're not able to perform positive pressure ventilation efficiently. Only 2% of the babies may go on to require an advanced airway, that is an endotracheal intubation, in whom positive pressure ventilation is not effective with bag and mask or with T-piece resuscitator, and in whom you anticipate they are going to require longer PPV. But it is to be remembered that ventilation of newborn's lung is the single most important and effective step in neonatal resuscitation, and it should not be delayed. So here we can see you can use a self-inflating bag and mask or a T-piece resuscitator and flow inflating bag and mask. So all of these can be used to provide positive pressure ventilation, and it is important to use a correctly sized either anatomic or a round mask. So it should rest on the chin and it should cover the mouth and the nose, but the mask should not be covering the eyes, and a tight seal should be formed to ensure that there is no leak. Now, coming to use of oxygen during neonatal resuscitation, we can see in this graph that immediately after birth, there is a rise in PaO2 occurring minutes after birth, which was initially 25 to 30 mm Hg. It rises, it goes up to 50 to almost 80 mm of Hg within minutes after birth. And it has been shown and proven by these studies that room air at 21% oxygen is sufficient to cause the pulmonary vasodilation in the term babies. So we initiate the resuscitation with 21% oxygen. However, in extremely preterm infants, 21% oxygen may not be adequate to mediate the pulmonary vasodilation. So they may require a reasonably higher FiO2 of maybe approximately 30%. And only in case you go on to require chest compressions, the FiO2 should be increased to 100%. So the age-old practice of beginning the resuscitation with 100% oxygen is no longer valid and is not recommended. So again, we see in this pictorial that for babies above or equal to 35 weeks of gestation, you initiate the resuscitation with 21% FiO2. For preterm babies, 29 to 34 weeks, you may start anywhere between 21 to 30%. And for extremely preterm babies, less than 28 weeks, initiate with at least 30% FiO2. In case you go on to require chest compressions, immediately increase your FiO2 to 100%. But as soon as there is a return of spontaneous circulation and there is no lung disease underlying in the baby, wean back to 21% to avoid the harmful effects of oxygen therapy. Or if it is a preterm baby or some lung disease may be there, so you can come back to 30 to 40%, and then subsequent FiO2 would be titrated based on the target pre-ductal saturations, which have been clearly mentioned by the NRP guidelines. Coming on to chest compression. So although most of the babies would, by providing effective positive pressure ventilation, would respond to it, but in case the baby does not respond to positive pressure ventilations that move the chest, for at least 60 seconds, they may go on to require chest compressions if you still found that the heart rate is less than 60 beats per minute, despite providing them with effective PPV. And it has been seen that such severely asphyxiated babies who had persistent bradycardia, it will result in significant low levels of blood oxygen. That is, there will be a significant hypoxia, buildup of PCO2 levels, and there would be a severe acidosis. So it results in a very poor coronary artery perfusion, thus leading to myocardial dysfunction and low diastolic blood pressures. So PPV alone may not be sufficient to cause the return of circulation in such babies. So chest compressions, which we provide by pressing on the lower one third of the sternum, because the rationale is that the heart lies between the sternum and the spine. So when you provide chest compressions, when you press, so it pumps the blood from forward in the, and it causes a rise in the pressure in the aorta. And when you release your fingers, it will cause that blood to refill back into the heart and improve the coronary blood flow. And by coordinating the chest compressions with ventilation, we will provide adequate oxygenation during the positive pressure ventilation until the myocardium recovers. So, it is recommended that the person who is providing chest compression should start at the head of the bed. Not only it will lead to the less mechanical fatigue of the compressor, it is anticipated that these babies may go on to require an intravascular access. So there would be a space for the another person to establish an intravascular access by putting an umbilical venous catheter. Chest compressions should be coordinated with positive pressure ventilation. So 3 compressions and 1 ventilation at every 2 seconds. And remember to increase to 100% oxygen, because there is a significant hypoxia which will not respond with lower levels of oxygen. And two thumb fingers technique, which we see in this picture. This is the preferred technique for providing chest compressions. Now, moving on to epinephrine, only even after effective PPV and chest compressions, there would be only approximately 0.05 to 0.06% of babies who will go on to require epinephrine. This is the only medication recommended by the ILCOR to be used in neonatal resuscitation, and it basically acts by acting on the alpha 1 receptors in the peripheral blood vessels and beta 1 receptors in the cardiomyocytes. So these babies who are uh, thought to have profound bradycardia, who have not responded to chest compressions, they are going to have a very, very severely decreased coronary artery flow. So the epinephrine is going to act as a it is a very strong vasoconstrictor. So it is going to act on the blood vessels outside the heart, and it will cause them to constrict, and thus it will increase the systemic vascular resistance, and hence improve the coronary perfusion pressure and the coronary flow. And by its action on the beta 1 receptors in cardiomyocytes, it will improve the rate and the strength of cardiac contractions. Epinephrine, it is you need to when the epinephrine is instilled, it is mandatory, it is recommended that it should reach the central venous circulation rapidly. So the most effective and the fastest way of providing epinephrine is via the intravenous, via the umbilical venous catheter, which has 100% bioavailability. In case it is not feasible or not, it is not successful, then intraosseous access may be used, which also provides 100% bioavailability. Other routes such as intratracheal or intramuscular are less preferred, because they lead to a poor and a unpredicted bioavailability of the drug. So we are not sure how much drug has actually gone into the circulation. So the key points to remember in neonatal circulation are that most of the newborns will make transition to extrauterine life without any intervention. The most important and effective step in neonatal resuscitation is to ventilate the baby's lungs. A bag-in mask or a T-piece resuscitator with an appropriate sized mask is used to provide positive pressure ventilation. Judicious use of oxygen should be made during resuscitation to avoid the harmful effects of hyperoxia, and very few newborns may go on to require chest compressions or medication if you provide effective positive pressure ventilation. These are the references. Thank you.